Okay, good afternoon to everybody. I want to start off this webinar welcoming you all, and I want to thank you to take part in this webinar on assessment and management of hypertension in dialysis patients. This e-seminar is jointly organized by EuDial, and EuReCa-M. EuDial or EuDial is represented by Professor Sande, who is a former board member. And I am Francesca Mallamaci, the chairwoman of the EuReCa-M, and the panelist will be Dounousi, which is a board member of the EuReCa-M, and again, Professor Sande from the EuDial. So the faculty is composed by the speaker, who is Professor Panagiotis Georgianos from Greece. I am the moderator, Francesca Mallamaci from Italy, and the two panelists are Evangelia Dounousi from Greece and Frank van der Sande from the Netherlands. I must say that this topic is a very hot one, because we don't have precise guidelines about how to make diagnosis and manage hypertension in dialysis patients, but I'm sure that Professor Georgianos will shed some light in this very complicated issue. So, Professor Georgianos, please, you can start your presentation. Thank you.
I hope that you can see my slides. And before starting my presentation, I would like to thank the board members of the EuDial and the EuReCa-M working groups of the European Renal Association for this honorable invitation to me. Here you can see my disclosures. And I will start my presentation with the most challenging aspect, the accurate diagnosis of hypertension. And in daily clinical practice, the conventional blood pressure recordings taken shortly before or after dialysis continue to form the basis for the assessment and the management of hypertension, mostly because these measurements are easily available to the nephrologist at the bedside. However, we have evidence from several studies and an earlier meta-analysis demonstrating that pre-dialysis and post-dialysis blood pressure recordings provide an imprecise reflection of the actual blood pressure load as this is recorded objectively with the reference standard technique of interdialytic ABPM. These recordings remain imprecise in diagnosing hypertension even if we use a standardized blood pressure measurement methodology. We can improve the diagnostic accuracy of these recordings if we consider jointly the blood pressure measurements taken during the dialysis procedure, and this study showed that the average of intradialytic plus peridialytic blood pressure reduces the bias and improves the accuracy and the precision of pre-dialysis or post-dialysis blood pressure recordings alone. However, this is a difficult method, requires the calculation of a mean value, and cannot be implemented to screen for hypertension at the bedside. We have much more reliable approaches to facilitate the diagnosis of hypertension in dialysis patients. And here we have the technique of home BPM, which is an established technique that is strongly recommended by guidelines for the assessment and the management of hypertension in the general population. And we have evidence from studies conducted specifically in patients on dialysis showing that home BPM improves the diagnosis of hypertension. In this analysis, systolic blood pressure averaged over 1 week at the cutoff point of 150 millimeters of mercury was the only blood pressure measure that provided a satisfactory combination of high sensitivity and high specificity in diagnosing ambulatory hypertension. And in a single-center study conducted in our university hospital, we showed that in peritoneal dialysis patients as well, 1 week averaged home systolic blood pressure was at least equal or even better than standardized clinic systolic blood pressure in diagnosing hypertension confirmed by ABPM. And there are also some additional advantages for this technique that should be taken into consideration. For example, home blood pressure can precisely track changes in interdialytic ambulatory blood pressure evoked by probing of dry weight. Home blood pressure is much more reproducible from 1 week to the next. Home blood pressure is much more closely associated with the presence of hypertension-mediated target organ damage and is much more informative in prognosticating the long-term risk of all-cause and cardiovascular mortality. Most importantly, an earlier randomized control trial from Brazil showed that as compared to a conservative management of hypertension with the guidance of routine pre-dialysis blood pressure recordings, a home blood pressure-guided antihypertensive strategy resulted in a significantly greater improvement in the ambulatory blood pressure control over 6 months of follow-up. Therefore, home BPM is not simply a diagnostic technique. Home blood pressure recordings are useful to guide our therapeutic decisions with the aim to improve the blood pressure control and the long-term clinical outcomes. The epidemiology of hypertension differs depending on how blood pressure was measured in the individual studies, and this table shows that studies that were based on routine pre-dialysis blood pressure recordings used variable definitions and provided considerably variable estimates of the prevalence and control of hypertension. A much more precise estimation of the actual burden of hypertension has been provided by a few studies that incorporating the gold standard technique of ABPM. For example, the EuReCa-M working group of the RADPA organized a multi-center cross-sectional study that included approximately 400 dialysis patients, showing that the prevalence of ambulatory hypertension is very high, 84.3%, despite the fact that the vast majority of hypertensives were being treated with multiple medications. Adequate ambulatory blood pressure control was achieved in only 28.7% of hypertensives. In a subsequent larger observational study, the EuReCa-M working group aimed to estimate the prevalence of apparent treatment-resistant hypertension. This study included approximately 500 dialysis patients from 10 renal units in Europe. Among 366 drug-treated hypertensives, 93 patients fulfilled the diagnostic criteria of apparent treatment-resistant hypertension, providing a prevalence rate of 24%. In a subset of 114 patients, the volume status was assessed with the method of bioimpedance spectroscopy either before or after dialysis. This diagram shows that approximately 1/3 of patients who were classified as having apparent treatment-resistant hypertension in fact had subclinical volume expansion. So the prevalence of true resistant hypertension in the dialysis population is not yet fully clear. We need to exclude some major and common causes of pseudo-resistance, such as volume-mediated hypertension, in order to diagnose the presence of true resistance to antihypertensive therapy. In sharp contrast to the direct and linear association between blood pressure and the outcomes in the general population, large-scale cohort studies conducted in dialysis patients have shown a J-shaped or a U-shaped risk association of blood pressure with mortality. This paradoxical risk association has been labeled as reverse epidemiology of hypertension, raising substantial concerns and uncertainty on whether hypertension in dialysis is truly an independent cardiovascular risk factor that should be adequately controlled. However, the phenomenon of reverse epidemiology is opposed by two different sources of evidence. First of all, we have evidence from observational studies showing that the risk association between blood pressure and mortality is modified by the technique of blood pressure measurement, and these studies showed that increasing levels of home systolic blood pressure and increasing levels of ambulatory systolic blood pressure were strongly and independently associated with an increased all-cause mortality risk. In sharp contrast, neither routine nor standardized peridialytic blood pressure recordings appeared to be of prognostic significance. And the other source of evidence comes from two earlier meta-analyses of RCTs, demonstrating that deliberate blood pressure lowering with the use of antihypertensive medications offers cardiovascular risk reduction in dialysis patients. The first meta-analysis was published in Lancet, included 8 RCTs, and showed that as compared with placebo, active treatment with antihypertensive drugs resulted in a significant 36% reduction in the risk of cardiovascular morbidity and mortality. The second meta-analysis showed that the cardioprotective benefit was greater when individual RCTs, including only hypertensive patients, were combined separately from RCTs that included also normotensives. Therefore, antihypertensive therapy and blood pressure lowering offers cardiovascular protection in the dialysis population, particularly when these patients are hypertensive. The optimal blood pressure target for this specific population remains unknown, and this is clearly illustrated in this slide, with the exception of a level C recommendation from the 2005 KDOQI guideline. All the subsequent guidelines released over the past few years did not make any specific recommendation for the optimal blood pressure targets in patients on dialysis, and the only trial that explored this important issue was the blood pressure lowering in dialysis, the BID trial. In this study, 126 hypertensive dialysis patients were randomized to achieve a titer versus a standard control of standardized dialysis unit systolic blood pressure. The blood pressure target in the intensive arm was between 110 and 140 millimeters of mercury versus 155 to 165 in the less intensive treatment arm. The BID trial achieved a good between-arm separation in the levels of systolic blood pressure at 4 months of follow-up. The investigators speculated that the BID trial provided a signal of safety with intensive blood pressure lowering. However, a closer examination of the adverse events indicates that as compared with the conservative treatment, intensive blood pressure lowering was associated with an increased risk of hospitalization and an increased risk of vascular access thrombotic events. The regression of LVMI, a pre-specified secondary efficacy endpoint of this trial, was not significantly different between the two treatment arms. Overall, the BID was a feasibility trial aiming to inform the design of a full-scale trial. A full-scale trial to fully elucidate the optimal blood pressure targets is still warranted. However, we have reasons to believe that even a standardized dialysis unit blood pressure is not an optimal target for managing hypertension in patients on dialysis. We have evidence that a home blood pressure guided antihypertensive therapy is superior to a strategy, a conservative strategy that is based on dialysis unit blood pressure recordings. Once hypertension is accurately diagnosed with the use of out-of-dialysis blood pressure recordings, then the management of hypertension initially relies on non-pharmacological strategies aiming to achieve and maintain the euvolemia. And here we have four pillars of therapy: the adequate management of dry weight, the restriction of dietary sodium intake, the individualized prescription of the dialysate sodium concentration, and the adequate delivery of dialysis. Direct evidence that uncontrolled hypertension in dialysis patients is a clinical manifestation of volume excess has been provided by the DRIP trial. This important trial was published in 2009. In this study, 150 hypertensive hemodialysis patients were randomly assigned in a 2-to-1 ratio in an intervention group and a control group. In the intervention group, dry weight was probed with gentle and gradual intensification of ultrafiltration over 8 weeks of follow-up. In the control group, 50 patients received only physician visits and served as time controls. At 4 weeks of follow-up, a small reduction by 0.9 kilograms in post-dialysis weight in the intervention group provoked a placebo-subtracted reduction of 7.4 millimeters of mercury in interdialytic ambulatory systolic blood pressure, and a placebo-subtracted reduction of 3.6 millimeters of mercury in interdialytic ambulatory diastolic blood pressure. This blood pressure lowering effect was maintained till the completion of the DRIP trial at 8 weeks. These important results have clinical implications for the management of dry weight in daily clinical practice. Notably, patients eligible to the DRIP trial had no overt clinical signs or symptoms of volume excess before the randomization. These patients were being treated with an average of 2.7 blood pressure lowering medications daily. However, the reduction in the dry weight, the improvement in volume status, was the intervention that provoked a clinically meaningful improvement in the ambulatory blood pressure control. In our opinion, this clinical trial data directly support a volume-first approach in the management of hypertension in patients on dialysis. Dietary sodium restriction is another established non-pharmacological intervention that aims to limit the interdialytic weight gain and aims also to facilitate the dry weight achievement. We have small interventional studies and a recent meta-analysis showing a small but clinically meaningful improvement in the blood pressure control with the dietary sodium restriction in dialysis patients. Dialysis sodium loading in patients on dialysis also occurs when we prescribe an inappropriately high dialysate sodium concentration. This results in a positive dialysate to plasma sodium gradient, and therefore we have intradialytic sodium gain that is directly associated with an increased sense of thirst during the post-dialysis period and with higher increments in the interdialytic weight gain that necessitate a more aggressive management of volume and a more aggressive ultrafiltration during the subsequent dialysis treatments. These higher UF rates can thereafter predispose to a higher risk of intradialytic hypotension, and then this can lead to a necessity for an even higher dialysate sodium concentration. This is clearly a vicious cycle. And how can we interrupt this dangerous vicious cycle? We have evidence from small pilot randomized control trials showing that the individualized prescription of the dialysate sodium concentration that takes into consideration the pre-dialysis plasma sodium levels is an effective strategy to limit the interdialytic weight gain and to improve the blood pressure control without aggravating the risk of serious symptomatic intradialytic hypotensive events. And among several other risk factors, non-adherence to the prescribed dialysis regimen has been associated with worse blood pressure control, and this is also illustrated in a post-hoc analysis of the DRIP trial. This diagram shows that in the intervention in the control group, there was a rising pattern in the intradialytic blood pressure levels. In the intervention group, probing of dry weight reduced the levels of intradialytic blood pressure, irrespective of the duration of the delivered dialysis. However, patients with shorter delivered dialysis required more dialysis sessions to achieve the blood pressure lowering effect that was provoked by the probing of dry weight. Therefore, the delivery of dialysis is another important intervention to facilitate the adequate management of volume status and the improvement in the blood pressure control. When hypertension remains unresponsive to these non-pharmacological strategies, then non-volume dependent mechanisms are invoked to explain the persistently elevated blood pressure. In this rather common scenario, the prescription, the administration of antihypertensive drugs, and the intensification of antihypertensive therapy is the second-line approach to normalize the blood pressure levels and to improve the long-term clinical outcomes. And this table provides a summary of the guidelines released over the past few years for the pharmacotherapy of hypertension in patients with earlier stages of chronic kidney disease. All these guidelines consistently recommend the use of an ACE inhibitor or an ARB as first-line antihypertensive therapy. In contrast, the beta blockers are not included in this table. Beta blockers are not recommended as first-line agents, and these agents are useful when we treat hypertension in patients with specific cardiovascular indications for beta blocker use. However, we believe that this therapeutic strategy may not be applicable for the management of hypertension in patients on dialysis, and we propose a rather different treatment algorithm for this specific population because we believe that the management of hypertension in dialysis should not be guided by extrapolation of RCTs that were conducted either in the general hypertensive population or in patients with pre-dialysis CKD. This table provides a summary of some major RCTs that tested the safety and efficacy of different antihypertensive drug classes specifically in the dialysis population. And the cardioprotective benefit of RAS blockade is not yet fully clear for those patients receiving dialysis. The individual RCTs have been few, have included small number of patients, and have provided largely contradictory results. In a recent updated meta-analysis, we showed that as compared with placebo, ACEs or ARBs did not significantly reduce the risk of fatal or non-fatal cardiovascular events. ACEs or ARBs had no clear benefit on cardiovascular mortality and no clear benefit on all-cause mortality. The HDPAL was an open-label trial that provided a head-to-head comparison between an ACE inhibitor-based regimen and an atenolol-based regimen. 200 hypertensive hemodialysis patients were randomized to receive atenolol or lisinopril, both administered 3 times per week immediately post-dialysis. Monthly monitored home systolic blood pressure was targeted to levels below 140 millimeters of mercury with a combined antihypertensive strategy that included the probing of dry weight, sodium restriction, and the administration of antihypertensive drugs. Contrary to the original hypothesis that a lisinopril-based regimen would be superior to atenolol, the home systolic blood pressure levels over the 12-month follow-up were persistently higher in the lisinopril group than in the atenolol group. despite the need for a more aggressive management of dry weight in the lisinopril group and the need for a greater intensification of the background antihypertensive therapy in lisinopril-treated than in atenolol-treated patients. Most importantly, this trial was closed early for cardiovascular safety reasons. The combined safety outcome of MI, stroke, and heart failure hospitalization occurred more commonly in the lisinopril group than in the atenolol group. This clinical trial data indicates that an atenolol-based, a beta blocker-based antihypertensive regimen may be more effective than an ACE inhibitor-based regimen in improving blood pressure control and in preventing the risk of major adverse cardiovascular events. These provocative clinical trial data require, however, confirmation by a larger phase 3 randomized controlled trial. Lastly, the guidelines recommend the use of the steroidal MRA spironolactone as the optimal or standard of care treatment of resistant hypertension in the general population. However, once again, the benefit-risk ratio of MRA therapy in patients on dialysis is not yet fully clear. In this meta-analysis of 9 RCTs, as compared with control therapy, MRA therapy was associated with a potential benefit on cardiovascular mortality. However, as with respect to the safety, MRA therapy was associated with a threefold higher incidence of hyperkalemia. These meta-analytic data should be carefully interpreted because the majority of the trials included in this meta-analysis had an unclear or a high risk of bias due to methodological limitations, such as small sample sizes or short duration of follow-up. Given the risk of hyperkalemia and in anticipation of larger ongoing trials that will be published in the forthcoming future, we do not routinely use a steroidal MRA for the management of hypertension in patients on dialysis. We are awaiting much stronger evidence from 2 larger ongoing randomized controlled trials. Thank you so much for your attention.
Thank you, Professor Georgianos, for this very complete and well thought presentation. I ask now Eva to make her comments about or suggestions about this presentation.
Okay, Professor Mallamaci, I would like first to thank about being a part of this very interesting and hot e-seminar, joint seminar between EuDial and EuReCa-M. And I'm more happy to see that more than 200 colleagues are attending the seminar right now. Professor Georgianos have given an excellent talk. That's what I believe. And I would like, I have made some notes, and I would like to refer to some key points of his presentation. As Professor Georgianos said, hypertension in dialysis patients is still a big challenge. Even the diagnosis of hypertension in these patients is nowadays has a lot of gray zones. He has shown us that dialysis unit blood pressure recording are not precise, and home blood pressure monitoring recommended by guidelines improve the diagnosis, and it is useful to guide us in order to take our therapeutic decisions in our patients. Ambulatory blood pressure measurement is much better, but it has some problems, like it is not available and it is costly. Regarding epidemiology, I mean, it is we saw that more than 80% of our patients have a hypertension from our dialysis patients, and 1/3 patients is not well controlled, despite the fact that we try hard with the volume management, and also most of them are taking multiple blood pressure lowering agents. In our dialysis patients, we see again the paradox of reverse epidemiology. However, there are studies showing that when hypertension is adequately diagnosed, then higher blood pressure is associated with higher mortality risk. I think that Professor Georgianos have overemphasized the fact that although pathogenesis is very complicated in our patients, the adequate management of volume excess is the principal strategy to achieve adequate blood pressure control in our patients. And in the case that we fail to control the blood pressure with the adequate volume management, then we have to go with the antihypertensive treatment. And in this case, well, there are some pilot studies showing that renin-angiotensin aldosterone system is not first-line treatment in our patient, with a big question mark, okay? And they have shown that beta blockers or CCBs are might better in this subgroup of patients. And I will end by saying that in our patients, after so many years of dialysis, we don't have clear blood pressure targets. It is just an expert opinion, and we don't know how much we have to reduce the blood pressure in our patients. And at this point, I would like to say that we have to join again forces to have large randomized controlled trials with maybe home blood pressure measurements this time, so that we end to well-defined blood pressure targets in our patients. Thank you very much.
Thank you, Eva. Professor Georgianos, do you want to reply to what Eva said? Or?
Yes, Professor Dounousi provided a brief summary of the data presented in this seminar, and I would like to say that the most crucial issue is that we don't have an optimal blood pressure target in this population, and we really need a randomized control trial in this particular field. However, we should not maintain the status quo, and we should treat hypertension in these patients. And several trials conducted so far have used home blood pressure monitoring, and I can say that a home systolic blood pressure target below 140 millimeters of mercury may be a reasonable target of therapy until the completion of a full-scale randomized trial that will fully elucidate this crucial issue. It's quite safe to go the home systolic blood pressure below 140.
I think that the first thing that we have to underline is that we must control volume in dialysis patients in order to control blood pressure. And this is what we have first to do in these very high risk patients, the volume control. In fact, in the frequent dialysis, in hemodialysis trial, the control of the volume was related to mortality, was related to left ventricular hypertrophy, and so on. And the control of volume was also related to sleep apnea, and with the optimal control of volume, also sleep apnea in that trial was reduced, the proportion of patients with sleep apnea. Now, Professor van der Sande, do you want to make comments, suggestions on this presentation, please?
Yes, I hope you can hear me. I really enjoyed the presentation by Professor Georgianos. It gave a broad overview of hypertension, also on intrahepatic hypertension. When I heard the comments by Professor Dounousi and your comment on volume, I referred to your slide in the presentation by Georgianos, showing the slide on volume overload and hypertension. And when you look at that slide, you can see there's a wide overlap between the three groups with regard to volume overload. So there were patients with normal hypertension and also with volume overload, and a patient with severe hypertension but really fluid depleted, which I believe it means several liters negative. So I think it's not only fluid that is causing hypertension. I do agree that's an important factor, but I think there are more factors of importance. And Professor Georgianos showed nicely the different treatments with regard to when treating hypertension. He showed a lot of information on ACE and ARB. And of course, we all know that ACE inhibitors are dialysable and the ARBs are not dialysable. And perhaps Professor Georgianos could give some comment on the one drug therapy we should give to our patients. So not the ACE inhibitors, but perhaps the ARBs. And also perhaps some comment on selective beta blockers as carvedilol, that showed in some studies a positive effect in patients treated with hypertension. Of course, the frequent nocturnal trial shows some nice results. When we go back in the past, I go back to the data from France, showing that patients will be dialyzed for 8 hours, were beautifully normotensive and even hypotensive during dialysis without any complaints. At that time, volume was really regulated for a long session. So Professor Georgianos could perhaps comment on frequent nocturnal dialysis and the effect on blood pressure treatment. And finally, perhaps some comment on vasoactive medication, vasoactive drugs such as anadrolone and nitric oxide, one that could also have an effect on an increase in blood pressure. Of course, we don't know how to dialyze these vasoactive substances.
Okay, thank you so much for your comments. First of all, Professor van der Sande raised the issue of dialysability of some agents, and this is an important aspect. We don't have pharmacokinetic data, updated pharmacokinetic data to assess the dialysability, but some agents are removed by dialysis. For example, lisinopril and atenolol are two highly dialysable agents, and these agents have very different pharmacokinetic properties, and we can administer these drugs 3 times per week immediately post-dialysis to avoid the dialysability and to achieve an adequate interdialytic blood pressure control, because atenolol and lisinopril are long-acting agents. And to ensure the adherence of our patients to this therapy, because this antihypertensive regimen is much simpler and can be supervised. With respect to the issue of volume versus non-volume management and the volume and non-volume dependent mechanisms, yes, of course, I fully agree with you that volume is an important contributor, but it's not the only factor that is involved in the pathogenesis of hypertension. This is clearly evident in our daily clinical practice. The vast majority of our patients require the use of multiple blood pressure lowering medications. However, one important point here is that we don't need to intensify the antihypertensive therapy if we have not addressed the issue of volume. The volume first approach has a role here, because if you effectively address the volume and the patient remains unresponsive and uncontrolled, then you have to intensify the antihypertensive therapy, and then you have to consider additional mechanisms and the use of different antihypertensive drug categories that block different mechanisms. And the most important issue is that the extended duration dialysis, the nocturnal dialysis trials and the short daily dialysis trials showed clear benefits. As Professor Mallamaci told us a few minutes ago, these trials say that if we optimize the dialysis therapy, then we can control the hypervolemia, and we can achieve also an adequate blood pressure control, and we can facilitate the regression of left ventricular hypertrophy. So we need to be sensible, and we have to target different components to maximize the benefit for our patients.
Can I give a comment to that as well?
Yes, please.
Of course, volume is important, but high ultrafiltration rate, high ultrafiltration volume has also an effect on the RAS system, of course, increasing the renin, increasing angiotensin 1, and because of that, an increase in systemic vascular resistance, which has an effect on blood pressure. So I think volume is important, but not to negative volume.
You are perfectly right. It's not the only cause for hypertension in a dialysis patient, but maybe it's the most important. We have a lot of questions, and maybe I wanted to address one to Professor Georgianos. The first one that was done is what is your opinion on the role of ambulatory blood pressure monitoring in hemodialysis patients?
Thank you.
Yeah.
Thank you so much for this question. ABPM is the gold standard technique. This technique provides much more information than every other technique. We take several blood pressure measurements over an entire 24-hour interdialytic interval. We can measure blood pressure during periods of resting and also during periods of activity. We can record blood pressure during the period of sleep, and we can facilitate the diagnosis of nocturnal hypertension, and we can identify patients who are non-dippers or reverse dippers. However, this technique is costly, is not broadly available, and I cannot imagine that there are several dialysis patients who will agree to repeatedly perform interdialytic ABPM every 3 months or every 4 months in order to achieve a long-term monitoring of blood pressure with this technique. So we cannot use broadly this technique. If we have this technique available in our department, we can apply this method to specific patients, particularly those with sleep apnea or those who may have nocturnal hypertension. But we have the technique of home blood pressure monitoring as a more feasible approach for the long-term assessment and the long-term management of hypertension.
Yes, that I must say that I want to add that as a EuReCa-M working group, we have many data about the feasibility of repeating 24-hour blood pressure monitoring. And we have to look at it very, very with much attention, because it's important. The patients don't want to repeat the 24 hours or 48 hours blood pressure monitoring, because it's not so easy for them. But as you said, the home dialysis is certainly a very good surrogate, but a surrogate. Another question is, do we have evidence that specific goals can improve mortality in dialysis patients?
If I have to answer this question, I don't want to repeat what we have already said. We need a randomized control trial here, but we don't need to maintain the status quo. We need to treat hypertension. We need to use out of dialysis blood pressure recordings. And although a clear answer cannot be provided, perhaps controlling home systolic blood pressure below the threshold of 140 millimeters of mercury is a reasonable target for to manage hypertension in dialysis patients. We really need a full-scale randomized control trial for clear evidence.
You see, I think that these two working groups, the EuDial and the EuReCa-M, we could set up a trial on these topics we have just mentioned. It could be a very good aim to do this kind of trials. And another thing is, maybe you didn't pointed out in a strong manner that if we measure the relationship in the general population between the blood pressure and mortality and the cardiovascular death, it's a linear one.
Mm-hmm.
In hemodialysis patients, you said that it's a J-curve. But if we measure home blood pressure, this relationship becomes also in dialysis patients linear, like in the general population. So it's the matter is how we measure blood pressure, how we assess blood pressure in dialysis patients. And as you said, we painfully need some clinical trials. Okay, there are so many questions. Another one is resistant hypertension in hemodialysis patients. Do you want to say some words on this issue?
Resistant hypertension is a particular phenotype that identifies high-risk patients with very difficult to control hypertension. We have evidence from the EuReCa-M working group of the era that the prevalence is as high as 24%. We actually do not know the prevalence of true resistant hypertension, but we need to mention that a dialysis patient with uncontrolled blood pressure despite treatment with 3 or more antihypertensive drugs requires a careful attention. We need to perform a diagnostic workup to this patient. We need to confirm the blood pressure control status using home BPM or ABPM. We need to assess the adherence to the prescribed antihypertensive regimen, because non-adherence is an important cause of pseudo-resistant hypertension. And then we have to carefully assess the volume status of this patient, because a high fraction of these patients may have volume responsive hypertension. If this patient remains uncontrolled despite all these non-volume management strategies that we have described, then the management of this patient is very difficult. However, I believe that it's only a minority of the patients that will have refractory hypertension even after a careful workup and after a careful management of the dry weight and after strict restriction of dietary sodium intake and after optimization of the delivered dialysis. I believe that there are a few patients who will fail to achieve adequate blood pressure control after all these interventions. I don't know if the panelists have something to add to this aspect.
If you don't, do you want to add something to this comment of Professor Georgianos? Frank or Evangelia?
No, I'm fine with his comments. I think he's right that there are some patients, whatever you do, they will still be hypertensive even after a thorough workup.
Eva?
Yes, I completely agree with Professor Georgianos about what he has said. But I would like to comment on another phenomenon that affects some a small but percentage of our patients, the intradialytic hypertension.
Yeah.
When a patient comes with a systolic blood pressure of 150 and during the dialysis session it goes up. So what can we do in this situation? Is it a matter of the overactivation of the RAS system or sympathetic nervous system? Can we do anything about these patients? I don't know if Professor Georgianos would like to comment on this issue.
You mean the treatment of intradialytic hypertension?
Yeah, this is another important phenotype. We don't have a clear definition in the literature. Intradialytic hypertension has been defined differently across studies. However, we know that approximately 10 to 15% of our patients present this paradoxical rise in blood pressure from pre to post dialysis. However, we have some ABPM studies that investigated patients with intradialytic hypertension, and when these patients underwent 24-hour interdialytic ABPM, it was made clear that these patients have also elevated blood pressure outside of dialysis. So we can say that intradialytic hypertension and interdialytic hypertension are two simplex, are very similar and interrelated conditions. And so when we have a patient in our unit with persistently a rising pattern in the intradialytic blood pressure, we should suspect that this patient is possibly uncontrolled outside of the dialysis session. We should ask this patient to measure his blood pressure outside of dialysis, and then we should follow the treatment algorithm that we typically use for the management of hypertension, which is the adequate management of volume status and then the intensification of antihypertensive therapy. Some clinicians consider that this is a rapid response. Let's say that we have to stop the ultrafiltration and prescribe an ACE inhibitor because there is an acute activation of the RAS, but the pathogenesis is possibly much more complex. This is my picture for this topic, and we need also some specific studies, some studies conducted specifically in patients with intradialytic hypertension to identify if an ACE inhibitor is much more effective in this subset of patients, perhaps.
And maybe the final, very crucial question is, do we need, and it's an obvious one, do we need an updated set of guidelines?
Okay. Of course, the management of hypertension in dialysis patients is largely based on expert opinion, and the EuReCa-M working group of the ERA-EDTA has published in 2017 a guideline paper, and the EuDial working group has also published several papers to specific aspects related to the management of sodium and the management of volume status. Perhaps we need a rigorous and updated guideline, but in my opinion, we first need large randomized controlled trials. Otherwise, an updated guideline will finally conclude to recommendations with a very low grade indication or to expert opinion once again.
Thank you, Professor Georgianos. I think that we are at the end of our webinar. What you say, I think that you gave a very deep lecture of what happens in hypertensive dialysis patients. The main message maybe is that we have to control volume, but there are also other causes for hypertension in dialysis, and we painfully need clinical trials, and maybe our working groups could do something about that. Thank you very much, and thank you for your attention and the participation that was very large indeed. Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.